Thank you so much for the introduction. Can everyone hear me? All right, great. So thank you so much for this invitation and your attention to talk about what I think is an important topic for us in clinical practice. The term de-prescribing came about 15 years ago, primarily from the elderly care and palliative care population. And since about 2 years ago was brought to psychiatry, and now we're trying to move forward applying it to child and adolescent psychiatry. We'll talk about the reasons that I think that's particularly important. I want to say one other thing. I think that this term can sometimes be misconceived, and I don't know how familiar you are with the term de-prescribing. It is the one we drew on from the literature, but I think that it can sometimes make people feel a little bit defensive, or that their prescribing practices are under scrutiny. And I don't think that's the case. We'll get into that a little bit, but I really think that this is just about providing the best clinical care that we can. So I have no disclosures or financial conflicts of interest. So this is what I hope to accomplish today. My goal would be to be as useful to you all as possible, so please let me know if you have questions or feel free to interrupt me. We'll start by defining de-prescribing, talk about its application to psychiatry and specifically child and adolescent psychiatry. As is integral to all of medicine, and particularly prescribing and de-prescribing, we'll talk about analyzing risk-benefit ratios. And then we'll go, how do you do this, the process of de-prescribing? And weave throughout will be a case presentation to help demonstrate some of the principles. So this is one definition of de-prescribing. It's a process of applying a systematic approach to identifying and discontinuing medications when existing or potential harms outweigh existing or potential benefits. And this is very important that it's a collaborative process with patients and their families using a shared decision-making type of application, and that it's done with the values and goals of the patient and the patient and their family in this case, and also keeping in mind their current functioning. Stated another way, it's the planned and supervised process of dose reduction or stopping of medication that might be causing harm or no longer of benefit. You'll notice these focus a lot on medication. I think that medication is one part of de-prescribing for child and adolescent psychiatry, just like our treatments compared to other medical specialties are broader, include psychotherapy and things like that. So I'll explain that more in a minute. So de-prescribing is not a message that medication is harmful. It's also not synonymous with medication cessation. And as we talked about earlier in that stigma, it's not an assumption of inappropriate prescribing. The medications may have been started for a very good reason or a very clear indication. That doesn't mean that we still need to reassess the need for the medication moving forward. So the other way I'll state this isn't just for bad doctors, it's for everyone. And it's part of good prescribing, using the minimum effective dose and the minimum number of medications possible to achieve our treatment goals. I did make some changes to the slides, and you'll notice that I moved this over-prescribing from the not to the maybe. I would like to think that de-prescribing stands independent of current concerns about over-prescribing, but I do think that's why we're paying so much attention to this right now. There's increasing rates of psychotropic prescribing. We know that Medicaid populations are at higher risk, and even within that, foster care populations are at higher risk of being exposed to polypharmacy. This is true and being discussed in our professional societies, as well as non-professional forums such as the media. So I think that that's related to why we're talking about this, but I hope it's not the only reason, because again, I think this comes back to trying to do our best for our patients. So now I'm going to start the case presentation. So this is a 10-year-old boy who's in 5th grade with a diagnosis of ADHD and unspecified depressive disorder. He's presenting to me with issues of significant hyperactivity and inattention, conflict with siblings, oppositional behavior with his parents, impulsive high-risk behavior such as running away from home, classroom behavioral issues, academic underachievement, and poor social skills. I'll also mention that one of the major triggers for parent-child conflict was homework, which will become important when we talk about our treatment plan. A few quotations from the family that represent where the youth and family were at this point in time. The parents said, "Xbox isn't just for him. We can't get anything done if he's not on it." And Dad had said at one point, "I've accepted the fact that he may never be fully independent and may need residential placement." So that just kind of demonstrates the severity of where parents were at, despite him having been in chronic treatment for about 3 years. So milestones achieved on time. He had chronic school challenges from the beginning, leading to an individualized education plan in the 3rd grade. He was about 25% on the weight and height curve and otherwise healthy, or including healthy. His father had symptoms of ADHD throughout his childhood that were never diagnosed or treated and had subsequently self-resolved. He was the middle child of a nuclear family in the Silicon Valley. They were financially stable, lived in a single-family home. Both parents worked full-time, and they had an after-school caregiver. So the medications when he came to me, lisdexamfetamine or Vyvanse, 40 milligrams daily, fluoxetine, Prozac, 20 milligrams daily, and risperidone, 1 milligram at bedtime. The medication history is provided by the parents. At 8 years old, he was started on lisdexamfetamine after 2 other stimulant trials that were not tolerated due to insomnia. Within a few weeks, he had developed intense mood swings and irritability and was then started on fluoxetine. This progressed to self-harm behavior, slamming his fingers in a drawer, banging his head on the wall, for which he was started on risperidone. So the initial records from the psychiatrist who started these medications were not available to me. These had been continued with only minor dose adjustments after seeing a series of other psychiatrists for about 2 years. He'd undergone a brief course of CBT with Coping Cat with an unclear impact. And he, for the past year, had been in supportive psychotherapy with the goal of helping him address his issues of self-esteem. What was striking to me about this treatment plan was that he had not apparently done well in home or school functioning over the past 2 years. So I think it's a fine treatment plan if it worked, but it wasn't working in this case. So he had, the IEP came with a certain amount of psychoeducational testing, which didn't show any specific learning disorders. There wasn't anything concerning for autism. Yes?
Medicating potential side effect of the first medication?
Yes.
So
Yeah, so we'll talk a little bit more about that. One of the things that's referred to as a prescribing cascade. So you put someone on a medication and then potentially, thinking you're identifying a co-occurring disorder, put them on another medication when really it was just a side effect to begin with. Or maybe you start a second medication knowing it's a side effect, but now you have polypharmacy. So you're going back to differential diagnosis, right? So what are we trying to treat here? And that's a really good point, yes. So his symptoms of depression were this kind of low threshold, like just kind of low mood and being withdrawn. He did have irritability. He slept a lot, but he was on risperidone. He didn't eat much, but he was on Vyvanse. So he did have some low self-esteem, nothing like suicidal ideation, yeah. We'll take 2 more and then I'll keep going, yes.
Okay, so I fully agree. I think there's a lot of the symptoms that he's still having consistent with ADHD. Mood swings you certainly see with ADHD, and depending on the time of day that's mood swing or the symptoms are, because again, with the stimulant providing it's effective in the morning but not in the afternoon, issues with homework, I think you alluded to.
Sure.
You're suggesting, I think those are, and then how much is he sleeping through?
Yeah.
Is he sleeping at night or is he sleeping during the day?
At night, he's sleeping at night, yeah, okay. Sorry, we had one more over here.
The family dynamics, I don't know if that was ever explored, was there any family therapy, parent counseling,
So you're talking about what are the psychosocial interventions we could implement in order to be more effective in our treatment plan. Great. Okay, so you guys covered a lot of important things, and thank you for participating so much. Again, feel free to interrupt me if you have questions or comments, but I'm going to talk a little bit more about de-prescribing, and then we'll get back to the case. All right, so in 2016, Gupta and Cahill published the first article bringing de-prescribing to psychiatry, not specifically to child and adolescent psychiatry. That was published in Psychiatric Services. They identify 3 main indications for applying de-prescribing to psychiatry. One is burgeoning rates of polypharmacy. 2, growing appreciation of long-term adverse effects of some of the medications that we use. And 3, increasing focus on patient-centered practices. And that's the collaborative piece. So why would this be particularly applicable to child and adolescent psychiatry? Because I think that it is. One is we deal with a vulnerable population who have limited cognitive abilities, rely on caregivers who may have their own limitations, and have mental illnesses that may impact their emotional and executive functioning. The medications that we prescribe, for the most part, are modestly effective for the indications that we use them for, while at times having serious side effects, leading to a narrow risk-benefit margin in best circumstances. The long-term impact of psychotropic medications on the developing brain is largely unknown. What are youth who were exposed to risperidone when they were 5, 7, 9, what are they going to look like in 20 years? How might their development or their brain development be changed? We don't know. Nobody's looked at it. Most evidence for the use of medications is based on short-term trials that last 6, 8, 12 weeks. But in clinical practice, we use medications much longer. Medications in child and adolescent psychiatry are only ever part of the treatment plan. They might be sometimes the most readily available, but they're certainly not sufficient on their own. And youth undergo normal development, meaning that their biology is changing, their psychological abilities are changing. So they might, as they develop, they might be able to better use therapy, their cognitive abilities in order to manage some of their symptoms. Their environments might be changing. Maybe things are different at school or in the home. So, as discussed, risk-benefit analysis is integral to understanding, as is understanding awareness that this is a dynamic process and changes over time. Risk-benefit analysis is influenced by biology, health, and illness. One of the most striking examples might be pregnancy, where the risks of medications essentially change overnight. Illnesses such as obesity changes the risk of some of the medications we use, such as atypical antipsychotics. And risk-benefit analysis is related to disease severity. So for example, antidepressants are more effective in youth who are more depressed, whereas mild to moderate depression might be better treated with psychotherapy. So in trying to calculate risk, specifically looking at youth, this should take into account cumulative exposure over time. Starting medication in childhood leaves more potential years of total exposure. Youth are at higher risk of side effects, for example, metabolic syndrome and extrapyramidal symptoms, including tardive dyskinesia, and compounded risks of polypharmacy. So both the number and severity of side effects increases as the number of medications increase. So weighing the risk of each medication is not sufficient when multiple medications are present. So this isn't additive. We must account for 1, drug-drug interactions, and 2, as we talked about, limited data on the safety of drug combinations. So there may be risks that we have not yet even identified. And then we have to try to account for risk moving forward into the future. So even if there is a positive clinical response and no current side effects, this must be weighed against potential long-term adverse events and limited knowledge about long-term neurodevelopmental outcomes. I think this cartoon here, so it says, is there a pill I can take to make me feel better about the pills that I take? And I think this also reminds us to think about what impact the medications have on the youth and their perspective of themselves and themselves as a healthy or not healthy person. So we talked about definition, and so we're going to talk a little bit about outcomes, and this goes back to the literature on geriatric patients. So de-prescribing has been associated or shown to reduce adverse drug reactions, improve rates of medication adherence, reduce financial costs, and in studies specifically looking at psychotropic medications, including benzodiazepines and antipsychotics, to reduce fall risk and improve cognition. Mortality was on this list in the previous version of the slides. That's been true in some observational studies, but more recently been called into question. So there was a Cochrane review looking at the withdrawal of long-term antipsychotics for behavioral and psychological symptoms in older people with dementia. This was first done in 2013 and updated a few months ago. And they state that antipsychotics may be successfully discontinued in older people with dementia and neuropsychiatric symptoms who have been taking antipsychotics for at least 3 months, right? So they're saying that there's no reason to continue these long term. They found withdrawing antipsychotics had no effect on behavioral symptoms or relapse. They were uncertain about the effects on cognition, quality of life, or mortality, but cited low quality evidence to draw these conclusions. They supported their earlier conclusion that discontinuation programs of antipsychotics should be incorporated into routine clinical care. So what outcomes have we seen in child and adolescent psychiatry? And this is a little bit more difficult. There have been some observational studies at residential treatment centers, one also in juvenile justice, that medications can be safely reduced without exacerbating symptoms or behavioral issues. This is associated with improved outcomes, such as functioning at the time of discharge or success in aftercare. The confounder there is that this occurs in the context of a structured milieu and psychosocial interventions. Maybe confounder is not the right word. It's supplemental, right? So we're thinking about medications in the context of overall treatment, and this would say that if you provide more psychosocial structure and treatment, that you can safely reduce medications. Inpatient studies have suggested that optimizing rather than starting medications are associated with reduced readmission rates. So if youth came out of the hospital on the same number of medications in which they went into the hospital, they were less likely to be readmitted than if a new medication had been started. So there's no outpatient studies looking at this question. There are some withdrawal studies, meaning that a medication is continued for a certain amount of time for a specific indication and then discontinued. One that I was just looking at was for the use of risperidone in youth with ASD and aggression. And they found that, it was open label for 4 months, so youth were on risperidone at what doses the clinician thought was appropriate. And then at 4 months, they randomized them to either placebo or continued medication. They found that 60% of those who had switched to placebo relapsed, and 12% who maintained on the risperidone did not relapse, which is pretty striking. But if you look at it another way, that means that 12% of the kids weren't doing well anyway. So they were on risperidone, but it wasn't really helping them. And 40% were taken off and did just fine. So that's 50% that weren't benefiting from this medication. And the average weight gain was 12 pounds. So they were experiencing the harms, even though half of them weren't benefiting. Potential outcomes that might occur in de-prescribing in outpatient settings are an enhanced therapeutic relationship. Patients' families are probably thinking about this, and being able to collaborate with them about treatment planning might help to improve the therapeutic relationship. We know that patients stop their medications, and if we were willing or perceived as willing to have a conversation about this, we might be able to make it a collaborative process with proper monitoring and safety planning as opposed to people doing it on their own. So this is the practice parameter on the use of psychotropic medication in children and adolescents, and they state that a discontinuation trial may be indicated if there's a sustained period of remission and the prescriber believes the medication may no longer be necessary. The recommendation is to develop a specific plan, assess the potential for withdrawal and relapse, discuss this with the family, come up with an action plan, collaborate and monitor. So if you look specifically at depressive disorders, it recommends continuing medication for 6 to 12 months in the face of a positive response. That discontinuation could be tried during the summer as to not affect academic functioning, but also to look for example, emergence of anxiety symptoms if tapering an SSRI for depression that may have been treated incidentally. At least monthly appointments and the use of psychotherapy. So looking at anxiety disorders, they quote, "The benefits and risks of long-term use of SSRIs have not been studied." At the same time, cite an earlier article that recommends continuing the medication for a year, once stable. That trials should be again initiated during a low stress period, and also to restart the medication if there's a relapse. So I think to your point, It does not address if there's persistent symptoms. What do you do if the youth doesn't get better? And what do you do in the case that there's multiple medications involved? And so those are true of those are both true of the case that we were discussing. So where do I start? So these steps have been put forward by many of the articles from De-prescribing in the elderly, so it's sort of a consensus. So the steps here: complete a medication history, including all current medications and the reason for each. Consider risk of overall medicine-induced harm. So not each medicine specifically, but the total, the sum or the additive effects. Identify medications that could be ceased or reduced. Order the priority for discontinuation. We'll talk more about that in a second. This is a collaborative process, and then implement and monitor while moving forward. So this is a very busy slide. We're not going to go through all of it, but it is an example of an algorithm that was developed specifically for antipsychotics in the elderly. The first question is, why is the patient taking an antipsychotic? This breaks it down into 3 separate categories. One is for behavioral and psychological symptoms of dementia on the left. One is for primary insomnia, and on the right is for more primary underlying psychiatric conditions. So if we focus on the left, I'm going to blow that up. If the patient's been on the medication for more than 3 months, as was in the Cochrane review, they state that you should make a strong recommendation to taper and stop the antipsychotic. They even give you specific instructions, such as 25 to 50% every 1 to 2 weeks, what to monitor for, and finally what to do if there's a relapse. The first step if there's a relapse is to consider non-drug approaches. The second would be to restart the antipsychotic, though they also note if the taper is not successful that it should be retried again after a period of time, and then to consider alternate drugs. So we don't have similar guidelines for our youth, but if we want to think about what might be important steps for us to use, the first would be to start with a comprehensive psychiatric assessment. And this is especially true when care is being transitioned from another provider or if the youth is already on medication. Pay special attention to the effectiveness of the medication in regards to the original reason they were started. We talked about this earlier. Reviewing the literature, particularly when there's polypharmacy, as in many instances there will be limited empirical support. Evaluate potential contribution of adverse medication effect, right? We sort of wondered what the lisdexamfetamine might be doing in this youth. If you notice increased anxiety after starting a medication, is that anxiety or is that akathisia? Use of evidence-based psychosocial interventions, and choosing the right time. We don't want to do it when there's a lot of other stressful things going on. So which medications to discontinue? This is going back to, again, the literature on the elderly. Start with 1, those without a clear or valid indication. 2, that are part of a prescribing cascade, which we defined, where actual or potential harms outweigh the benefits. 4, if medications were ineffective or if symptoms originally targeted have resolved. 5, that are preventive in nature. That's the one that's a little bit more specific to that population. And 6, those that impose an unacceptable treatment burden. So if the functioning of the patient is more impaired on the medication than it was by their original symptoms, is probably not the right regimen. So specific to child and adolescent psychiatry, choosing medications to discontinue or prioritizing. Start with those with the least evidence of efficacy. So that's going back to the literature and how effective is this for the indication for which I want to use it. Those with limited effect based on history. Has this done anything in this case? Those with the greatest side effects or side effect risk. I think we all think about, like somebody mentioned, the risperidone or the atypical antipsychotics. Those that are prescribed at a supertherapeutic dose without justification, as that increases risk of side effects. And those prescribed at subtherapeutic doses, which may be clouding the picture, but not actually contributing much. So other considerations are the rate of taper, taking into account the half-life. Rapid tapering of anticonvulsants can precipitate seizures, even in youth who do not have them at baseline. We'll come back to this because it's very important. Make one change at a time. We have a hard time determining what is the effect of any intervention that we make. And making one change at a time gives us the best chance of being able to collect accurate data about the effects of the changes. And collect information systematically. So consider using standardized instruments or assessment tools. Patient factors, I'll go through this quickly because I want to get back to the case. Level of risk, is this someone who's had suicide attempts in the past or multiple hospitalizations? The timing and the context of change, what else is going on in their life? Alternative coping strategies, come up with a safety plan. The meaning of the change, is this a youth who is very excited to be getting off of medications and may not pay attention if they start to see some red flags? Or is it somebody who's seen these medications as a safety blanket and they might be very anxious about losing it? The strength of the treatment alliance, is this a family that is going to come to you if they have concerns? And try to address any misinterpretations. So discontinuing a medication is not the same as saying, treatment is no longer indicated. If symptoms recur, the first step is to wait. We all know that there's natural fluctuations in the course of an illness, and we don't want to assume that any change is related to something that we're doing. We also know that there's withdrawal syndromes, that withdrawal symptoms are real. We ask patients to allow time for their body to adjust going on to a medication. The same thing happens when you need to come off. Evaluate for other contributing factors. Did this youth just break up with their significant other? Probably makes sense that they're feeling a little more depressed. Increase therapeutic supports or consider implementing an alternative therapy. Resume medications at the last effective dose, or consider an alternative medication, perhaps one that has fewer risk of side effects. So returning to our case, in summary, a 10-year-old boy with past diagnoses of ADHD and unspecified depressive disorder, presenting with pretty classic ADHD symptoms, some oppositionality and possible mood symptoms, just the medications listed again. In thinking back to how do we proceed with de-prescribing, these are some of the steps that came to mind for me, was to collect some information systematically, apply some standardized rating scales, think a little bit more about the differential diagnosis, and look into the potential of adverse medication effects. So a self-rating scale showed mild to moderate depressive symptoms, and Vanderbilt rating scales, both teacher and parent, showed moderate to severe symptoms of inattention and hyperactivity. So it's pretty clear the youth has ADHD at this point. The other things, so how do we explain the rest of what's going on? Is it a mood disorder? It could be. It could also be that he's had a lot of negative feedback from his untreated or suboptimally treated ADHD, and that's led to internalizing some negative thoughts about himself. He didn't quite meet criteria for oppositional defiant disorder. His oppositional behavior was mostly at home, not so much present with peers or at school. Disruptive mood dysregulation disorder, given this kind of chronic irritability, or a medication side effect. So looking at the adverse effects of lisdexamfetamine in controlled trials, so in 3% of youth, it was related to affective lability, and in 10% of youth, it was related to irritability, compared to 0% of each of the placebos. So that's a real possibility. And on the bottom here, it says, you're right, morphing into a hideous monster is not listed as a possible adverse reaction. So going back to ordering the medications, we want to start with those without a clear or valid indication. I certainly have not seen the clear indication for risperidone or fluoxetine. Those with the least evidence of efficacy, and this youth has ongoing symptoms in several domains. So it's not clear to me which ones have been beneficial. If they have, it's not beneficial enough. We would like better. Those with the greatest evidence of side effects, that would clearly be risperidone, side effect risk, and the rate of taper, or the half-life, so we can think about prioritizing, or how that fits into our overall taper. So lisdexamfetamine has the shortest half-life and fluoxetine the longest, and then we want to make one change at a time. So our plan was to stop lisdexamfetamine at the end of the week, start methylphenidate the following week, followed by a slow taper off of risperidone, which was chosen first due to its more concerning side effect profile, as well as its half-life. It would have taken a very long time to allow fluoxetine to clear a system and be certain that any effect from that had dissipated. And the last step was to taper off of fluoxetine. Our goal at this point was monotherapy with a stimulant, at which point we could reevaluate his symptoms and consider augmentation. and incorporate evidence-based psychosocial interventions. So, psychosocial interventions. He had weekly psychotherapy in addition to meeting with parents 1 to 2 times a month. Parents had a really hard time with this idea of de-prescribing. They were very nervous about the effects of taking him off some of these medications. Even though we could kind of agree that they didn't see the results they would like, they still also, at the same time, they felt like that these were very powerful things and tools for them. Parents attended a behavior management group based on PMT, and some of the topics are listed here. I won't read them. The youth participated in an organizational skills training class with a goal of increasing his independence in his schoolwork. The school updated his IEP so that it included a study skills class, as well as a teacher who was assigned to monitor his agenda and assignment completion to take the parents out of this role at home. And then we struggled with a behavior plan. It was very hard for the parents to limit that Xbox time. The youth was not happy about that. Over time, they started to make some progress and actually see some results. So what happened? He went from lisdexamphetamine to a combination of long and short-acting methylphenidate and had some improvement in his irritability and depressive symptoms. He was slowly tapered off risperidone and then fluoxetine with no worsening of his mood or impulsive behavior. Makes me wonder, had we been medicating a side effect from the Vyvanse all along? But the big confounder here was that his parents had participated in PMT, and they actually found that very helpful for changing the dynamic between them and the youth. So he was getting a lot less negative feedback, which may have made him feel better about himself and more capable. So what we had at this point was some improvement in his ADHD, though persistent symptoms. He was having weight loss above 50 milligrams a day, which limited our dosing. At the same time, parents were willing to consider drug holidays because his behavior had improved so much they felt more comfortable. He was having some insomnia, so we started melatonin and then ended up adding clonidine for continued hyperactivity, impulsivity, and insomnia. So he's still on polypharmacy. So this is not, necessarily a polypharmacy solution, although this I would say pretty clearly has a less serious side effect profile and fewer long-term risks. Risperidone may have been mitigating some of his weight loss and treating some of the insomnia, but I don't consider either of those an indication for this medication to stay on his drug list. And there's actually good evidence for combination stimulant and alpha agonist for what we are considering as primary diagnosis of ADHD. So how did we get here? I'll spend just a minute or two thinking about how do we end up in this situation of polypharmacy and unclear effectiveness? In this case, there was incomplete records when transitioning healthcare systems, which brings up these questions of what did the medication do when it was started, what am I missing? There were multiple handoffs. This youth had seen 4 different psychiatrists over a period of 3 years. And we were trying to address diagnostically ambiguous symptoms such as oppositionality and irritability, which could be related to any number of disorders, but specific to none. In general, I think that providers have a fear of making behaviors worse in making medication changes, and that this is seen as a risky business. There's sometimes an assumption that medications have been continued by previous providers for a reason, so we sort of conclude effectiveness by their presence, and that might not always be the case. There is some evidence, for this youth, there is some evidence of efficacy of using risperidone to lower aggression in youth with ADHD, but I still don't think that makes it the best regimen for him. I'll just talk about some of the challenges that we have that are specific to psychiatry in trying to apply de-prescribing. Psychiatry has fewer objective metrics than many other specialties. We focus on symptomatic rather than functional outcomes. We rely a lot on individual subjective experience, both in figuring out their diagnosis, but also the effectiveness of our interventions. We have discontinuous treatment relationships and disjointed systems of care, which makes it, like we said, difficult to evaluate the necessity of a medication. Research focuses on the early effects of treatment, even though clinically that's not always what's most useful for us. And there's a lack of guidelines and data on discontinuation, which makes providers One, it makes it hard to make these decisions. We don't have a whole lot to rely on, and it also makes it more frightening. So in conclusion, we need more research on the outcomes of our prescribing practices, such as the ideal duration of medication use, the effects of polypharmacy, and functional outcomes of de-prescribing. And we need a process to systematically and safely reassess the need for medication, including developing guidelines and algorithms to guide clinicians. Thank you.
Thank you.